I'd like to thank the International Federation for inviting me to be a discussant here today. And I told Andrew when I was coming in, because first I accepted, then I saw the size of the report, and I kind of regret it. But then it made a very interesting read, and I thank you for the opportunity. And I like to say right now I'm at UNAIDS, but I can't forget my past, because I was until August last year, was the STD, AIDS, and viral hepatitis director with the Minister of Health in Brazil for 6 years. So I have like a first-hand experience in negotiating price negotiations with all R&D companies, and also I was very intimately related to the process that led to the compulsory license of efavirenz in Brazil, and also led to the non-granting of the tenofovir patent. So this background, say now I wear UNAIDS hat, but I'm still, I'll always be Brazilian, so can't hide that. And I would say that I come from a medical background, so I'm not an IP specialist. I've been dealing with it, but I'm not an IP specialist. And I'm also not a scientist like Brenda with the methodology parts and so on. So I think we have some lessons learned, all of us, during these 30 years of the epidemic. Like we learned that HIV has issues of equity and human rights, and that kind of shows in this report, that there's a close relation to access to treatment, to health services, priorities, and right now with the flatlining of fundings and so on for HIV, focused interventions, better efficiencies are all very much in line with the current global thinking, right? I like to, on the lessons learned, and I'd like to say some things before I comment on the report. At the end of last year, we had almost 7 million people in treatment. We are going to release the new numbers now in November. And these people are living in low and middle income countries. And access every day, still every day. Last year we had 7,000 deaths every day. And this is the vast majority in what's called the global south. So I've seen this report and in other reports and then in other conversations we have or round tables, and we classify people according to where they live. And whether they live or die, it's very much related to where they were born, and in this way. And we classify people according to their countries, actually, right? So it's per capita income, and it's the prevalence, and also it's you kind of lose sometimes the human feeling of access to treatment when we do this type of categorization. I understand it's important, we have to do it, but we lose when we do that as well. Right? Also, I think you showed the different indicators, and Brenda mentioned we have whatever you choose, we can have, because HIV it's one of the most, I think it's the most studied disease ever, right, that mankind ever had. We have all kinds of stuff. So whatever you choose as indicators, you can have results, different results, depending on what you choose. And that's a choice, actually, right? I understand some of the choices we do when we do a study like this, so comprehensive, is very much related to what's available, published, and so on. Another thing that we learned was the value of a public health approach to treatment. So with HIV, we moved, from the kind of individualized clinical approach to having an overall view. We need, all of us, to think on the public health approach, and that's why we have guidelines, WHO guidelines, and so on. And right now, the situation is that we have HIV AIDS as a chronic disease, and there's no cure not in my lifetime, I suppose, but it's going to be there for a long time, and health systems, pharma, and all the global organizations, countries have to deal with that. So any time we're talking about putting people into treatment, we are talking about lifelong treatment, long term. And that changes things. And right now we even had this trial that came out in May on the treatment as prevention for serial discordant couples, which brings another element, which is that treatment that can also not only save lives, type of business we are in, but can also prevent new infections. So, yeah. And now we have this political commitment of 15 million people in treatment by 2015. So I think the launch of this report is very timely, because we had the high-level meeting this year, we have a reaffirmation of the commitments to universal access to treatment, we have targets, and we also have the 10 years of the Doha Declaration. So it's in a way, it's symbolic in many, many ways. So UNAIDS welcomes the results of these studies and the opportunity to discuss them today, and I'm sure there will be other discussions around this report, because it raises some issues that are where I think there is an easy consensus, but raises issues as well where there will be lots of controversy. So I'm going to just touch on a few of them. I liked very much the way you correlated the key factors for increasing access in the 7 countries, and especially when you didn't forget to put overcoming stigma as a key factor, because that's when you see in many countries what we call now as with the new investment framework, the critical enablers for treatment programs. Many times you don't see them reflected in countries, and that's a very important analysis. One thing that I think maybe you could explain a little bit more, it's because one of the main issues one of the main differences of the AIDS response that made a difference, for example, why AIDS was not something like TB or something like I call the old public health diseases, was because of universal access treatment. There was a huge civil society mobilization, and that doesn't appear like one of the. You treated that as a cross-cutting issue, and not as something that had a role in itself. That was, I think, was one of the main things. You refer to it when you talk about political will, we refer to it to partnership, but it's more than that. It was really the mover and shaker of this response came into life because of the civil society mobilization. The other thing on the political will, I understand political will refers to long-term commitment, and that includes sustained financial commitment. And it's not, so it's a key factor. It's not only like when you cite Botswana and Brazil, and also you put Brazil and Botswana as far ahead because on coverage, because we started earlier. But on the other hand, South Africa had the fastest growth scale up in history for any kind of thing. And that's a huge effort from the government part and from the scientists and from the health workers and communities that work there. And that somehow is not reflected because of the type of approach you had on this. And it requires probably a stronger political will to do it this way than it did, when we started the epidemic in the 90s, start treatment both in Botswana and Brazil.